Now let's talk about the question number 12. I am Dr. Prakhar Gupta, your surgery mentor. So what we have in the question is that a young diabetic patient who comes to you with vomiting, abdominal pain and deep labor breathing, as you already know that these are the classical signs of diabetic ketoacidosis. Now his potassium level is 5.6 and ECG shows peaked T waves. Now the moment you see this, you feel that we are dealing a patient with hyperkalemia. What in the question they are asking is that after 2 hours of insulin administration, he develops muscle weakness and cardiac arrhythmia, and what is the likely cause for the sale. Now, as you already know that in diabetic ketoacidosis, the insulin level is almost zero. So without insulin, the glucose cannot enter the cell, and so the potassium also stays outside, because insulin normally helps in pushing the potassium into the cell through sodium potassium pump. As a result of which, the extracellular potassium concentration goes on increasing. On the other hand, in addition to that, because of the acidosis the patient is suffering from, there will be increased concentration of the hydrogen ions and too many hydrogen ions floating in the blood. Now these hydrogen ions enter the cell to get buffered, and to keep the charge balanced, the potassium, it leaves the cell and enters the bloodstream. So this is again another reason that why the extracellular or serum potassium level goes on increasing. So what you particularly see is that extracellular or the serum potassium levels are too high in diabetic ketoacidosis, despite the fact, because potassium is a primary intracellular ion inside the cell, it is severely depleted. Now when you start insulin, what happens immediately is that this insulin begins doing what it always does. That means it drives the glucose and potassium into the cell, and suddenly when all the potassium that was sitting in the bloodstream rushes back into the cell, the serum potassium level, it drops. So what happens after insulin administration? Insulin activates the serum potassium ATPase, thereby driving the potassium into the cells, and acidosis starts getting corrected. The hydrogen ion, it leaves the cells, as a result of which the potassium enters the cells. So the result is that there will be rapid intracellular shift of the potassium, leading to serum hypokalemia. And this is the reason that the patient would be experiencing muscle weakness, arrhythmias, or even cardiac arrest. And this is exactly what has happened in our case. If you go back to the question, that after 2 hours of insulin administration, he developed muscle weakness and cardiac arrhythmia. So which of the following explains this sudden deterioration? And the answer for this question is insulin-driven intracellular shift of potassium causing hypokalemia. So this was a basic physiological question, and how these questions are particularly asked in the examination, keeping in view this very important table, that whenever you are managing a patient of diabetic ketoacidosis, you have to look at the serum potassium levels first. So the rule is that if the potassium is below 3.3 milliequivalent per liter, then don't touch insulin yet. You have to first fix the potassium and start IV KCL till the potassium reaches the safe zone of 3.3 to 5.0 milliequivalent per liter. Now in this case, you have to start with the insulin but keep adding potassium to the fluids. That means the insulin along with the potassium supplementation. While in the case where the potassium levels are too high, you can start insulin right away, but you have to monitor the potassium level every 1 to 2 hours, because it can fall rapidly, leading to deadly consequences. So I hope you have understood the topic, you have understood the concept. All the best for your preparation.